All right, for the last session and taking on from where Gauri left off, using data to make this world a better place is something that is something that inspires me. And our next speaker is going to talk about how he is using data, machine learning, and AI to improve health outcomes and patient experience. So I'd like to welcome on stage Dr. Wade Schulz from Yale. Welcome, Dr. Schulz. Thank you, sir. All the best.
Thank you for the introduction. So my name is Wade Schulz. I'm at the Yale School of Medicine. And today I'm going to talk to you a little bit about how we're using big data in healthcare and give you a couple of different use cases that we've actually implemented in production. And a couple of the areas that I want to focus on is one where there's a lot of interest recently, which is precision medicine. And at Yale, we cover a large portion of Connecticut. So we're a large tertiary care facility, academic hospital, and we're really trying to take advantage of all of the data that we have available to really improve those patient outcomes. And precision medicine has been of particular interest in the media. There's been a lot of funding opportunities around this with the All of Us initiative, as well as the Cancer Moonshot, which many people are probably familiar with. And a lot of the interest has been driven by the fact that we don't think that all of our treatments right now are probably the best tuned to any particular individual. Most of our studies are based off of large cohorts and large populations because that's how we figure out if we see therapeutic differences when we develop new technologies, new drugs, new medications. And to illustrate this, if we imagine that this graphic represents 25 people who all have the same disease or diagnosis. For simplicity, let's say hypertension. Right now, what we would typically do is treat them all initially largely the same way. We would give them the same medication, we would give them the same procedure, but we know that outcomes don't necessarily happen in all of those patients. So some people might have an adverse reaction, some people may not see a decline in their blood pressure. And is that really the way that we should be practicing medicine? Should we be treating every individual as one of the giant population? Or can we take advantage of many different data points, knowing that people have different genetic makeups, different backgrounds, different medical histories, and develop these different treatment groups where we could better place individuals in therapeutic categories to see better outcomes? The problem that we start to run into is as we start to subdivide these large groups of patients into smaller and smaller cohorts, we start to see that our healthcare data sets that we traditionally rely on really aren't that big compared to a lot of other industries. The electronic health record, while contains a large wealth of information, is often very dirty data, sometimes very incomplete. The other thing that we run into is that for many institutions, they have not been electronic for that long. We've really only seen the push to move to digital records over the last 5 to 10 years. So if you look at any particular institution, they may only have a couple years history of patient data where they move from paper charts to the electronic record. Even when we look at data sources like medical imaging, laboratory testing that generate larger sums of data, for any particular disease, especially rarer diseases such as some types of cancer, there may not be a sufficient number of patients to really put and subdivide them into these categories where we could deliver better precision and targeted therapies. Fortunately, the increases in new technology offers unprecedented access to larger volumes of health-related data. This includes things like continuous patient monitoring, wearable devices, next generation or whole genome sequencing, and taking all of this information can start to develop a more complete picture of our patients and participants in trials to, again, deliver on that precision medicine promise. The data supports this explosion in data. Research by numerous different companies has shown that we really aren't limited to acquisition of data from a single care encounter anymore. You don't need to come into the physician's office to have your blood pressure or your weight taken. We can do that with devices in the home. And work again from a number of different companies has shown that from 2015 to 2016, there was an estimated increase by about 50-fold in the amount of medical data being generated. This was driven partly by novel data types like that whole genome and next generation sequencing, as well as the fact that now worldwide there are about 4.9 million individuals on remote and home monitoring. One key aspect of healthcare data, though, is that about 80% of our information is unstructured. Clinical notes, laboratory data, laboratory results, Some of it's discrete, but largely it is unstructured, which creates unique challenges for data scientists in the field. The other thing that we run into is all of the traditional issues of securing and storing and managing these data, now that we're seeing far larger volumes. In healthcare, just like everywhere else, we have our data silos and a lot of barriers to transformative analytics within the industry. This isn't necessarily unique to us. Like some of the other speakers mentioned, we can all argue who has been the most laggard in adopting these technologies. But healthcare definitely does have specific regulatory requirements that are different from other industries. And we also end up with a lot of vendor lock-in. If you have a specific electronic health record, it sometimes becomes very difficult to change to another vendor. Same thing goes for laboratory information systems, as well as even laboratory instruments. Getting data out of those systems can be difficult, complex, and there aren't a lot of very good standards. So healthcare does have standards in terms of messaging, but many of them are very complex and what I would term flexible. Not everybody actually implements them as the standard actually recommends or requires. However, the benefits of these big data sources have really driven healthcare to try to catch up with the rest of industry. So how can we move from our traditional approaches of locking data in and looking at it at the level of a single patient and really diving into a more comprehensive data lake approach where we can take information from our traditional enterprise or clinical data warehouses into a system that can also support these emerging large data types. We can't necessarily put all of our whole genome sequencing in the EHR. It won't scale, so we needed platforms that can support this. And at Yale, we've started to deploy a fairly large computational health cluster where we can do exactly this. In addition, we're trying to get other data sources that haven't traditionally been available to healthcare providers, patient and participant-generated data, wearable devices, patient-reported outcomes from mobile devices. How can we get that, integrate that, and get that back to providers to actually take meaningful actions? And one thing that we've tried to do within our data science environment is really try to avoid this kind of standard approach, which is just acquire the data, we'll deal with it later, but we're going to do great things. How can we instead take that step 2 and actually try to form specific questions around the data that we're acquiring? That way we can better structure it, better index it, and try to get to where we can actually make some clinically relevant outcomes earlier on in the process rather than just capturing terabytes and terabytes of data. And to illustrate this, I'm just going to walk through a few of the production use cases that we've done at Yale. We've presented some of these at the Data Summit in Munich and also have a talk tomorrow about how we're implementing some of these in China as well for a large research study. But the first use case that we really had presented us with the problem of trying to reduce alarm noise within our intensive care units. So we have patients connected to a large number of monitoring devices in our ICUs and our ERs as well as other areas within the health system. And alarm noise is a problem for providers as well as for patients. So if alarms are going off when they shouldn't be, providers become tired of them, they start to silence them and ignore them. So you start to lose the actual signal in the noise. The other thing is that hospitals aren't necessarily the most pleasant place for patients to be. And if you're in the ICU, one thing you don't want is being constantly woken up by alarms, especially if they're unnecessary. So we had a big push from our nursing to figure out how can we reduce the alarm noise in our units. Fortunately, we had great interaction with a lot of our biomedical device group within the health system. We were able to hook our data feed in from all of these alarms that generate signals every 1 to 5 seconds and send all of that data into our Hadoop cluster. So we go in through Kafka, use Storm for most of our processing, put it in HDFS, and then do some of the analysis with Spark. After implementing this pipeline, currently we acquire about 6 to 9 billion data points per month within the system. We were actually able to reduce the number of alarms by about 50% within our ICU at Yale-New Haven Health. We're now starting to expand this out to the rest of the health system, and we were also able to improve patient satisfaction by reducing that alarm noise. One of the other very exciting things for me, being in the clinical laboratory, is actually business intelligence based off of all of our laboratory data. And what we had here was a need to try to better identify where is our laboratory testing volume happening, what's our turnaround time, are we delivering on our results as we need to for our customers within the health system itself. Also, could we improve quality assurance of our instruments? Can we tell when an instrument is starting to move out of analytic range? And we took a very similar approach where we piped this in and used NiFi or Hortonworks data flow to actually ingest and manage that data. And then if anybody's interested, you can actually see an entire pipeline of this. We've got the code on GitHub, actually based off of the Hortonworks sandbox that goes from generating artificial laboratory data through data storage and then through visualizing in Zeppelin, where you can actually look at laboratory volumes and generate moving averages, all within a notebook, and it's very simple to get these up and running. And then the last use case I wanted to go through was our clinical genomic results, and this is something that is, again, a very large interest to a lot of healthcare organizations within the country and in the world, really. And we had the instance where we actually have 3 different labs that perform next-generation sequencing within the university and within the health system. However, all of those results we wanted in one place so that we could do data analytics. And so for this, we again acquire all of our data, store that in HDFS, and are starting to do some analysis with Spark. And we're actively working on expanding the capacity and capabilities of this platform to integrate other types of healthcare data, as well as outside sources of genomic testing. All of these use cases that I just presented, we actually brought online over the course of about a year and have had in production for about the last 12 months at this point. And some of the keys to being able to successfully deploy some of these very complex pipelines over such a short period was really the integration and being able to engage all of our IT groups very quickly. So being able to work with our Office of Information Security to make sure that we had data security and governance early on, making sure that everything was encrypted as we needed to, that we could audit and log everything, and also being able to work with our existing data warehouse teams to acquire and capture data out of the clinical data warehouse and put that into the data science environment. From the clinical provider perspective, again, we wanted to try to identify questions whenever possible. We never give up a data source, but we try to structure it as much as possible when we initially obtain it. And the other benefit that we had at Yale is we actually have a very large group of clinicians, both nurses and physicians, who are actually trained in analytics and able to really drive some of these use cases, and some of those people are here at the conference as well. Being able to really collaborate between these groups is definitely a challenge. People are spread out, often in different locations, but has really been key to being able to implement and deliver results on these technologies. And the last thing that I wanted to touch on before I end today is really the importance of being able to communicate the results and the importance of these technologies to others. And one of the quotes that I've always liked is by Jeff Leake out of Johns Hopkins, and it starts with, "Data science done well looks easy." So one of our approaches is actually using convolutional neural nets to try to do a task that actually requires physicians right now. So if you have a blood specimen taken, and there are certain indexes that are out of parameter, so your red cells might look like they're the wrong shape, there might be too many, too few, or if a physician orders a manual interpretation for some reason, diagnosis of leukemia or a number of other rare diseases, those tubes of blood then get put drops on a slide and then put under a microscope where a physician actually has to interpret and look at the big slide of all the red cells and the different morphologies, so how many of each different shape of red cell is on that slide. And right now it's very qualitative. There might be an increase in what we call schistocytes, which is the 3rd cell, or the dacrocytes, which is the 4th. And being able to really deliver those interpretations is difficult. So what we developed was a convolutional neural net that actually can just print off the percentages of each of those cell types pretty efficiently. And to most people, it looks pretty easy. We put in an app, you can run apps on your phone, you get out a graph. How hard could it be? But the way that that quote ends is that because it sometimes looks easy, is that's a big problem for data scientists, because for anybody in the field, we know it's much more complex. We need far more data to start with. Somebody actually has to go in and label it or do some feature engineering. After that, we need somebody with some expertise in machine learning to actually develop out our networks and models to do and test those models before we implement them. And then that doesn't even get to trying to implement that into a production workflow and pipeline, which can take a significant amount of time, especially within something that needs clinical validation. So being able to communicate those results and show what resources you need, how much time and effort needs to go into that, is very important to ensure that as a field, we can adequately staff and get resources to push these projects through and deliver on the exciting opportunities. So in summary, big data is definitely hard. It takes a lot of work to acquire and clean these data. There's definitely concerns around storage, governance, and security. And then making sure that we can understand those problems, especially if there's not immediately available domain expertise, is problematic. Healthcare adds on some additional burdens or overhead, especially within the realm of regulatory limitations. However, there is exciting and big opportunities within this field and many others. Being able to reduce our cost and increase our treatment efficiency, do things like fraud detection within insurance claims, as well as deliver again on that promise of personalized treatment and population healthcare, means that by taking advantage of these exciting technologies, we finally have the opportunity to deliver some of the best care we've ever experienced. Thank you very much, and enjoy the rest of the conference.